My name is Tom Hutson. I am the director of the GU Oncology program with Texas Oncology at Baylor Sammons Cancer Center, where I also co-chair the Urologic Cancer Research and Treatment Center. I'm a professor of medicine at Texas A&M College of Medicine, and I run the Early Development Phase 1 program for Sarah Cannon Research Institute. When we are starting to think about what treatment options would be best suited as therapy for our patients with advanced renal cell carcinoma, it's important to understand the mechanism of action of the various agents and how that lines up with our own understanding of the pathogenesis of the disease process. One of the greatest breakthroughs in understanding how to treat renal cell carcinoma was the discovery of the von Hippel-Lindau gene mutation as not only being the culprit behind von Hippel-Lindau syndrome when there's a germline mutation, but it is the most common acquired mutation producing clear cell renal cell carcinoma in patients. And with that understanding from the 1990s and what the von Hippel-Lindau gene does, its downstream effects, how that relates to angiogenesis, has prompted the development of multi-targeted kinase inhibitors that target angiogenesis. And what we think is the putative main driver of angiogenesis is the vascular endothelial growth factor receptor and pathway. And so there have been the development of targeted therapies that will specifically block the activity of VEGF at the receptor level, as well as a variety of other things that we have now discovered are important as escape mechanisms that lead to resistance, and also by themselves have anti-kidney cancer or renal cell cancer activity. So these would be other receptors such as PDGF, c-KIT, and in the case of lenvatinib, FGF receptors. And so understanding which particular therapy hits these particular receptors helps us choose which therapy we're going to utilize first. So mechanism of action is of utmost importance in cancer in general, and in the case of kidney cancer, very important because we know that we want to inhibit certain things that we have shown are important in the development of that particular cancer. Adverse reactions, some of which can be serious or fatal, may occur with LENVIMA, including hypertension, cardiac dysfunction, arterial thromboembolic events, hepatotoxicity, renal failure or impairment, proteinuria, diarrhea, fistula formation and gastrointestinal perforation, QT interval prolongation, hypocalcemia, reversible posterior leukoencephalopathy syndrome, hemorrhagic events, impairment of thyroid-stimulating hormone suppression, thyroid dysfunction, impaired wound healing, osteonecrosis of the jaw, and embryo-fetal toxicity. Based on its mechanism of action and data from animal reproduction studies, LENVIMA can cause fetal harm when administered to a pregnant woman. Females of reproductive potential should be advised to use effective contraception. Based on the severity of the adverse reaction, LENVIMA should be interrupted, reduced, and/or discontinued. As with any medication, it's important to review the adverse reactions in the prescribing information. It is important to note that most patients will need dose modification strategies as guided by the prescribing information to help manage adverse reactions during their treatment journey. It is important to consider the mechanism of action of a targeted therapy when making a selection in renal cell carcinoma, because these therapies have been designed specifically to inhibit factors that are involved in the pathogenesis of renal cell carcinoma. Lenvatinib is a kinase inhibitor that inhibits the kinase activities of vascular endothelial growth factor, VEGF, receptors type 1, VEGF receptor type 2, and VEGF receptor type 3. Lenvatinib inhibits other kinases that have been implicated in pathogenic angiogenesis, tumor growth, and cancer progression, in addition to their normal cellular functions, including fibroblast growth factor, receptors 1, 2, 3, and 4, platelet-derived growth factor, receptor alpha, KIT, and RET. Lenvatinib also exhibited anti-proliferative activity in hepatocellular carcinoma cell lines dependent on activated FGFR signaling with a concurrent inhibition of FGF receptor substrate 2-alpha phosphorylation. Targeted therapy drugs treat kidney cancer in different ways. Some target and block the signals that cause new blood vessels to form. Others block the signals that tell the kidney cancer cells to grow and make more cancer cells. Lenvatinib and everolimus are as a combination of two targeted therapies with different mechanisms of action. Lenvatinib would be considered a VEGF receptor tyrosine kinase inhibitor that targets VEGF as well as other receptors believed to be important in the pathogenesis of the cancer, including platelet-derived growth factor, fibroblast growth factor, c-KIT, among others. Everolimus is an mTOR kinase inhibitor, and it inhibits the pathway of mTOR that's involved in normal cell homeostasis. The combination of lenvatinib and everolimus showed increased anti-angiogenic and anti-tumor activity as demonstrated by decreases in human endothelial cell proliferation, tube formation, and VEGF signaling in vitro, and by decreases in tumor volume in mouse xenograft models of human renal cell cancer that were greater than those with either drug alone.
Indication: LENVIMA, lenvatinib, is indicated in combination with everolimus for the treatment of adult patients with advanced renal cell carcinoma, RCC, following one prior anti-angiogenic therapy. Important safety information: warnings and precautions. Hypertension. In DTC, differentiated thyroid cancer, hypertension occurred in 73% of patients on LENVIMA. In RCC, renal cell carcinoma, hypertension occurred in 42% of patients on LENVIMA and everolimus. Systolic blood pressure greater than or equal to 160 millimeters of mercury occurred in 29% of patients, and 21% had diastolic blood pressure greater than or equal to 100 millimeters of mercury. In HCC, hepatocellular carcinoma, hypertension occurred in 45% of LENVIMA-treated patients. Grade 4 hypertension was not reported in HCC. Serious complications of poorly controlled hypertension have been reported. Control blood pressure prior to initiation. Monitor blood pressure after 1 week, then every 2 weeks for the first 2 months, and then at least monthly thereafter during treatment. Withhold and resume at reduced dose when hypertension is controlled, or permanently discontinue based on severity. Cardiac dysfunction. Serious and fatal cardiac dysfunction can occur with LENVIMA. Across clinical trials in 799 patients with DTC, RCC, and HCC, grade 3 or higher cardiac dysfunction occurred in 3% of LENVIMA-treated patients. Monitor for clinical symptoms or signs of cardiac dysfunction. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Arterial thromboembolic events. Among patients receiving LENVIMA or LENVIMA plus everolimus, arterial thromboembolic events of any severity occurred in 2% of patients in RCC and HCC and 5% in DTC. Grade 3 through 5 arterial thromboembolic events ranged from 2% to 3% across all clinical trials. Among patients receiving LENVIMA with pembrolizumab, arterial thrombotic events of any severity occurred in 5% of patients in CLEAR, including myocardial infarction 3.4% and cerebrovascular accident 2.3%. Permanently discontinue following an arterial thrombotic event. The safety of resuming after an arterial thromboembolic event has not been established, and LENVIMA has not been studied in patients who have had an arterial thromboembolic event within the previous 6 months. Hepatotoxicity. Across clinical studies enrolling 1,327 LENVIMA-treated patients with malignancies other than HCC, serious hepatic adverse reactions occurred in 1.4% of patients. Fatal events, including hepatic failure, acute hepatitis, and hepatorenal syndrome, occurred in 0.5% of patients. In HCC, hepatic encephalopathy occurred in 8% of LENVIMA-treated patients. Grade 3 through 5 hepatic failure occurred in 3% of LENVIMA-treated patients. 2% of patients discontinued LENVIMA due to hepatic encephalopathy, and 1% discontinued due to hepatic failure. Monitor liver function prior to initiation, then every 2 weeks for the first 2 months, and at least monthly thereafter during treatment. Monitor patients with HCC closely for signs of hepatic failure, including hepatic encephalopathy. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Renal failure or impairment. Serious, including fatal renal failure or impairment, can occur with LENVIMA. Renal impairment was reported in 14% and 7% of LENVIMA-treated patients in DTC and HCC, respectively. Grade 3 through 5 renal failure or impairment occurred in 3% of patients with DTC and 2% of patients with HCC, including 1 fatal event in each study. In RCC, renal impairment or renal failure was reported in 18% of LENVIMA plus everolimus treated patients. Initiate prompt management of diarrhea or dehydration hypovolemia. Withhold and resume at reduced dose upon recovery or permanently discontinue for renal failure or impairment based on severity. Proteinuria. In DTC and HCC, proteinuria was reported in 34% and 26% of LENVIMA-treated patients, respectively. Grade 3 proteinuria occurred in 11% and 6% in DTC and HCC, respectively. In RCC, proteinuria occurred in 31% of patients receiving LENVIMA plus everolimus. Monitor for proteinuria prior to initiation and periodically during treatment. If urine dipstick proteinuria greater than or equal to 2+ is detected, obtain a 24-hour urine protein. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Diarrhea. Of the 737 LENVIMA-treated patients in DTC and HCC, diarrhea occurred in 49%. In RCC, diarrhea occurred in 81% of LENVIMA and everolimus-treated patients. Diarrhea was the most frequent cause of dose interruption reduction, and diarrhea occurred despite dose reduction. Promptly initiate management of diarrhea. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Fistula formation and gastrointestinal perforation. Of the 799 patients treated with LENVIMA or LENVIMA plus everolimus in DTC, RCC, and HCC, fistula or gastrointestinal perforation occurred in 2%. Permanently discontinue in patients who develop gastrointestinal perforation of any severity or grade 3 through 4 fistula. QT interval prolongation. In DTC, QT/QTC interval prolongation occurred in 9% of LENVIMA-treated patients, and QT interval prolongation of greater than 500 milliseconds occurred in 2%. In RCC, QTC interval increases of greater than 60 milliseconds occurred in 11% of patients receiving LENVIMA plus everolimus, and QTC interval greater than 500 milliseconds occurred in 6%. In HCC, QTC interval increases of greater than 60 milliseconds occurred in 8% of LENVIMA-treated patients, and QTC interval greater than 500 milliseconds occurred in 2%. Monitor and correct electrolyte abnormalities at baseline and periodically during treatment. Monitor electrocardiograms in patients with congenital long QT syndrome, congestive heart failure, bradyarrhythmias, or those who are taking drugs known to prolong the QT interval, including Class 1A and 3 antiarrhythmics. Withhold and resume at reduced dose upon recovery based on severity. Hypocalcemia. In DTC, grade 3 through 4 hypocalcemia occurred in 9% of LENVIMA-treated patients. In 65% of cases, hypocalcemia improved or resolved following calcium supplementation with or without dose interruption or dose reduction. In RCC, grade 3 through 4 hypocalcemia occurred in 6% of LENVIMA and everolimus-treated patients. In HCC, grade 3 hypocalcemia occurred in 0.8% of LENVIMA-treated patients. Monitor blood calcium levels at least monthly and replace calcium as necessary during treatment. Withhold and resume at reduced dose upon recovery or permanently discontinue depending on severity. Reversible posterior leukoencephalopathy syndrome, RPLS. Across clinical studies of 1,823 patients who received LENVIMA as a single agent, RPLS occurred in 0.3%. Confirmed diagnosis of RPLS with MRI. Withhold and resume at reduced dose upon recovery or permanently discontinue depending on severity and persistence of neurologic symptoms. Hemorrhagic events. Serious, including fatal hemorrhagic events can occur with LENVIMA. In DTC, RCC, and HCC clinical trials, hemorrhagic events of any grade occurred in 29% of the 799 patients treated with LENVIMA as a single agent or in combination with everolimus. The most frequently reported hemorrhagic events were epistaxis and hematuria. In DTC, grade 3 through 5 hemorrhage occurred in 2% of LENVIMA-treated patients, including one fatal intracranial hemorrhage among 16 patients who received LENVIMA and had CNS metastases at baseline. In RCC, grade 3 through 5 hemorrhage occurred in 8% of LENVIMA plus everolimus-treated patients, including one fatal cerebral hemorrhage. In HCC, grade 3 through 5 hemorrhage occurred in 5% of LENVIMA-treated patients, including 7 fatal hemorrhagic events. Serious tumor-related bleeds, including fatal hemorrhagic events, occurred in LENVIMA-treated patients in clinical trials and in the post-marketing setting. In post-marketing surveillance, serious and fatal carotid artery hemorrhages were seen more frequently in patients with anaplastic thyroid carcinoma, ATC, than other tumors. Safety and effectiveness of LENVIMA in patients with ATC have not been demonstrated in clinical trials. Consider the risk of severe or fatal hemorrhage associated with tumor invasion or infiltration of major blood vessels, example, carotid artery. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Impairment of thyroid-stimulating hormone suppression, thyroid dysfunction. LENVIMA impairs exogenous thyroid suppression. In DTC, 88% of patients had baseline thyroid-stimulating hormone, TSH level, less than or equal to 0.5 milliunits per liter. In patients with normal TSH at baseline, elevation of TSH level greater than 0.5 milliunits per liter was observed post-baseline in 57% of LENVIMA-treated patients. In RCC and HCC, grade 1 or 2 hypothyroidism occurred in 24% of LENVIMA plus everolimus-treated patients and 21% of LENVIMA-treated patients, respectively. In patients with normal or low TSH at baseline, elevation of TSH was observed post-baseline in 70% of LENVIMA-treated patients in HCC and 60% of LENVIMA and everolimus-treated patients in RCC. Monitor thyroid function prior to initiation and at least monthly during treatment. Treat hypothyroidism according to standard medical practice. Impaired wound healing. Impaired wound healing has been reported in patients who received LENVIMA. Withhold LENVIMA for at least 1 week prior to elective surgery. Do not administer for at least 2 weeks following major surgery and until adequate wound healing. The safety of resumption of LENVIMA after resolution of wound healing complications has not been established. Osteonecrosis of the jaw, ONJ. ONJ has been reported in patients receiving LENVIMA. Concomitant exposure to other risk factors such as biphosphonates, denosumab, dental disease, or invasive dental procedures may increase the risk of ONJ. Perform an oral examination prior to treatment with LENVIMA and periodically during LENVIMA treatment. Advise patients regarding good oral hygiene practices and to consider having preventative dentistry performed prior to treatment with LENVIMA and throughout treatment with LENVIMA. Avoid invasive dental procedures if possible while on LENVIMA treatment, particularly in patients at higher risk. Withhold LENVIMA for at least 1 week prior to scheduled dental surgery or invasive dental procedures if possible. For patients requiring invasive dental procedures, discontinuation of biphosphonate treatment may reduce the risk of ONJ. Withhold LENVIMA if ONJ develops and restart based on clinical judgment of adequate resolution. Embryo-fetal toxicity. Based on its mechanism of action and data from animal reproduction studies, LENVIMA can cause fetal harm when administered to pregnant women. In animal reproduction studies, oral administration of lenvatinib during organogenesis at doses below the recommended clinical doses resulted in embryo-toxicity, fetotoxicity, and teratogenicity in rats and rabbits. Advise pregnant women of the potential risk to a fetus and advise females of reproductive potential to use effective contraception during treatment with LENVIMA and for 30 days after the last dose. Adverse reactions. In RCC, the most common adverse reactions observed in LENVIMA and everolimus treated patients were diarrhea, fatigue, arthralgia, myalgia, decreased appetite, vomiting, nausea, stomatitis, hypertension, peripheral edema, cough, abdominal pain, dyspnea, rash, decreased weight, hemorrhagic events, and proteinuria. The most common serious adverse reactions were renal failure, dehydration, anemia, thrombocytopenia, diarrhea, vomiting, and dyspnea. Adverse reactions led to dose reductions or interruption in 89% of patients. The most common adverse reactions resulting in dose reductions were diarrhea, fatigue, thrombocytopenia, vomiting, nausea, and proteinuria. Treatment discontinuation due to an adverse reaction occurred in 29% of patients. Use in specific populations. Because of the potential for serious adverse reactions in breastfed children, advise women to discontinue breastfeeding during treatment and for 1 week after the last dose. LENVIMA may impair fertility in males and females of reproductive potential. No dose adjustment is recommended for patients with mild or moderate renal impairment. LENVIMA concentrations may increase in patients with DTC, RCC, or EC, endometrial carcinoma, and severe renal impairment. Reduce the dose for patients with DTC, RCC, or EC and severe renal impairment. There is no recommended dose for patients with HCC and severe renal impairment. LENVIMA has not been studied in patients with end-stage renal disease. No dose adjustment is recommended for patients with HCC and mild hepatic impairment, child Pug A. There is no recommended dose for patients with HCC with moderate child Pug B or severe child Pug C, hepatic impairment. No dose adjustment is recommended for patients with DTC, RCC, or EC and mild or moderate hepatic impairment. LENVIMA concentrations may increase in patients with DTC, RCC, or EC and severe hepatic impairment. Reduce the dose for patients with DTC, RCC, or EC and severe hepatic impairment. For more information about LENVIMA, please see available full prescribing information.